A very warm welcome to all the nursing fraternity. I take this moment to thank the core team of National NNF for giving me this opportunity to speak on the topic of disinfection and sterilization being conducted in NICU. So before starting and before giving introduction, I just want to quote a very famous quotation by Florence Nightingale. She famously quoted that the very first requirement in any hospital is that it should do the sick no harm. So care must be taken that if any hospital which is giving care to the admitted patients, he or she should not feel that it is a battle place, but rather he or she should experience it as a healing place. So, my name is Jubilant James, and I work in AIMS NICU in the post of NICU Nurse Intensivist. So, talking about sterilization and disinfection, why are they critical in preventing HAIs in vulnerable newborns? So, before starting, we need to know what is sterilization and disinfection. So, sterilization, as we all know, that it includes complete elimination of all forms of microbial infection, including spores, whereas in disinfection, elimination of all pathogenic microorganisms occur, except bacterial spores. So, these are the main differences between both of them. So, why is it crucial in NICU? Newborns, especially preterm and low birth weight babies, and also incredibly low birth weight babies, have immature immune systems, or they are just developing to begin with a mature response to the growing systems. Infections can rapidly become life threatening. Equipment and surfaces come into frequent contact with babies and caregivers. So it is a mutual give and take. So it is our very responsibility to begin with an aseptic environment to provide a healing environment to the babies. Moving ahead, so we need to understand what are the main nursing considerations while beginning with infection prevention and also beginning with disinfection and sterilization. So when we talk about equipments for daily or terminal cleaning, so we need to understand that equipments that are coming in direct contact with the babies or in immediate contact with babies, we need to use soap and water only to daily clean it with. And the equipments which are far away from baby, we can use solutions which are based upon alcohol, aldehyde or hypochlorite to be used. Alcohol-based solutions to be avoided on transparent surfaces. We need to keep that in mind. And high potent disinfectants to be used for terminal cleaning. And we need to guide and supervise housekeeping personnel, which is our main and crucial responsibility, along with looking after babies. Ensuring appropriate use of PPE and dilution of disinfectants is carried out appropriately. Then, we need to understand that progression of cleaning should be made from least moist area to the most soiled area, that is, the metallic part of bassinet to be cleaned first, followed by the waves. Before redipping, mop should be covering an area of 120 square feet, and solution needs to be changed once the cleaning surface area of mop has covered 250 square feet, and rinsing of any solutions used prior to current cleaning or mopping. Further nursing considerations will be atmosphere to be kept always free from dust, all holes and crevices should be sealed, ambient temperature to be maintained between 25 to 28 degrees Celsius, overcrowding to be prevented at all costs. Every person entering the unit should perform hand hygiene. Number of handling by any professional or interprofessional cadre, including doctors, nurses, or any unit therapist, should be reduced. Floors and walls should be devoid of any cracks or crevices to prevent insect breeding and dust accumulation, as previously discussed. High contact surface areas such as doorknobs, lights, switches require specific and special attention. So moving on to hand hygiene, we will not be including and talking about the specifications of hand hygiene steps and like what all steps are involved in it, but rather what are the beneficial aspects involved and if there is any special considerations regarding hand hygiene. So we all know there are two types of hand hygiene. One is with alcohol drop and second one is with soap and water solution, right? So alcohol based hand rubs duration should be between 20 to 30 seconds as per WHO, and the hand wash should be 40 to 60 seconds. So why do we do the hand hygiene? What is the need for hand wash? Does hand washing reduce the spread of germs or microorganisms? So let's see what does the evidence says. Beneficial aspects include the scientific evidence intensely shows that appropriate hand hygiene is the single most effective action to stop the spread of infection. Second one is effective IPC, that is the infection prevention control measures include reducing of hospital-acquired infections as much by 55%, and newborn survival rates could potentially increase by 44% when hand washing and cleaning birth kits are in place. More than 50% of our work is done and dusted when performing hand hygiene. So nurses play a very crucial role in maintaining and performing the hand hygiene since they are doing 24/7 rotations with babies and taking care of them. And we have to understand that it is the most cheap and effective way to curb any spread of infection. What are the special considerations for hand hygiene? Ensure hand hygiene stations are always stocked up. Hand hygiene stations and areas are to be kept in near vicinity, which are easily visible. So these prompt to do hand hygiene further. Care should be taken not to refill alcohol-based hand rub dispensers as well as soap solution dispensers. We have to discard the empty ones and always use new stock. Scrub stations must be hands-free or auto taps. Scrub stations must be either wall-mounted or freestanding. Gloves do not replace hand hygiene, so we need to always remember that prior performing any aseptic technique and also before that, like while we are wearing gloves and also after removing gloves, we have to perform hand hygiene. While handling any chemicals or its preparation, we have to perform hand hygiene. Moving on to equipment decontamination. So what all equipments are included and used in NICU? Let's see, and along with the decontaminations and their frequency. So thermometers, tape measures, stethoscope, monitor probes, including the thermistor probes, saturation probes, torches as well as BP cuffs are to be steriled with 70% isopropyl alcohol impregnated wipes. And we have to use it daily and after each and every use and also in between usage of patients. Once we come in contact with infected O2 hood, we have to disinfect with 20% bacillus sheet. Oxygen hoods, multi-channel monitors, ventilator screen. We have to keep in mind that dry dusting should not be done. Clean it using a moist wipe that includes soap and water solution. If infected, with 20% bacillus sheet, and this has to be done daily. Ventilators air filter. We have to clean it with moist wipe and dust it off daily. Incubators, radiant warmers, transport incubators, if occupied by baby, with soap and water, that is daily, will be the frequency. For terminal cleaning with 20% bacillus sheet. And we have to always dismantle the parts which can be removed and cleaned. Next one is a bassinet or a baby cot. Wipe it with 20% bacillus daily and after each use. Weighing machine to be wiped off with 25% bacillol spray daily and after each use. Resuscitation and accessories. Dismantle, wash with soap and rinse under running water. Clean, dry and immerse in 2% Cidex for 6 to 8 hours after the rinse off with distilled water once dried, ready for use. This has to be done daily and after each patient contact or usage. Or we can also clean it with soap and water after dismantling and send for ETO, that is ethylene oxide. Whichever hospital has this facility can go through this. Next one is the cleaning of laryngoscope, wiping it off with spirit, and we have to use this frequency after each use or else daily. I will carry this topic later on. Ventilator tubings and CPAP tubings, if clean, can be sent for ETU, not to be changed weekly, only to be changed if visibly soiled or any breakage in the tube, as per recent studies says. So nebulizer tubings and ventilator attached tubings, these need to be dismantled along with their parts and washed under running water, sent for ETU, or after washing, dry and immerse in Cidex for 30 minutes after each use. CPAP body, ventilator body, nitric oxide machine, clean with bacillol spray, that is 25%, with soap and water for cleaning monitor screens daily. Incubator humidifiers, primary cleaning with soap solution and after drying, sent for ETO. Humidifier water to be changed at least every 8 hours, daily when in use. Suction bottles and O2 humidifiers, non-infected ones can be cleaned with soap and water daily. If infected, add 1% hypochlorite solution and immerse it in 30 minutes. And then we have to clean. Now moving ahead, linens including baby sheets, baby frocks, draw sheets, towels, hand towels, procedure sets. These need to be cleaned with soap and water and sent for autoclaving after each and every use. Then comes the glass bottles, articles or steel swab containers, chill faucets. These along also go with the same decontamination procedures, and these need to be conducted in a frequency of 24 hours apart. Syringe pump, infusion pump, IV stat. We need to wipe it off with 25% bacillol spray with a frequency of daily. And also if we can do it in each shift, that will be good. We follow the same procedure in AIMS, NICU. Phototherapy units, belly blanket, wipe it off with 25% bacillol spray daily. Head cooling machines such as Decotherm or Blanketrol or whatever machine is being used in each and specific NICU, wipe it with 25% bacillol spray daily. Feeding utensils such as small bowls, pallida, spoons, small trays, wash with soap and water and roll boil for 15 to 20 minutes after each and every use. Ultrasound probe of any size, transilluminator, wipe it off with 70% isopropyl alcohol daily and after each use. If they get infected, wipe with 1% hypochlorite solution. Ultrasound machines to be wiped off with 25% bacillol spray daily. Sponge bowls, primary wash and sent to CSST for autoclaving daily. Breast pumps, specifically individualized use for each patient, one per person. It may be not feasible in every hospital. Once it is being used for many patients, so we can wash it with soap and water and then sterilize the accessories by boiling it for 15 to 20 minutes. There is a mistake over here. After each use, breast pump machine to be wiped off with 25% bacillol spray, and it is need to be done daily. So going deep into how the sterilization of ventilator tubings is being done in NICU of AIMS and self-inflating bag as well as laryngoscope. So mostly we are here using ventilator named Sophie, that is the Stefani ventilator, which is an outsourced ventilator. So here the company parameter specifically has advised to change the ventilator tubings after 7 days after each and every disinfectant use. So we are disinfecting ventilator tubings after 7 days of use, taking out the ventilator tubings, washing it under running water and immerse it in soap and water solution. And after 30 minutes, we wash under running tap water, ensure that there is no water residue in the tubing in order to prevent dilution of glutaraldehyde. Once it has been dried properly, we completely immerse the tubing in glutaraldehyde 2% for 8 hours, taking out the tubing and wash with RO water. Dry the tubings by hanging them in clean space for 24 hours. After 24 hours, we pack the dry tubings in sterile double layer wrapper and put tape on it. Self-inflating bag. Disassembling the bag and clean it with soap and water. Immerse it in glutaraldehyde for 30 minutes. Wash under RO water. Dry by using sterile sheet and pack them for further use in clean and sterile bag. If the self-inflating bag is not being used, we have to disassemble the bag and use 25% bacillol spray to disinfect daily. If last usage is more than a week, sterilize by disassembling the parts of the bag and then re-immersing in 2% glutaraldehyde for 6 to 8 hours. This has to be done once per week if the bag has not been used since more than a week. Further, moving ahead with laryngoscope disinfection. Rinse it with soap and water. Disinfect in glutaraldehyde for 30 minutes. Final rinse it with RO water. Dry the laryngoscope and pack in sterile cotton bag. Laryngoscope valve, if removable, remove it and wipe with 70% isopropyl alcohol. If it is not being in usage, then disinfect with 70% isopropyl alcohol, pack in sterile cotton bag. Moving ahead, we'll see how the cleaning of incubator is done specifically. When the equipment is in use, all approachable internal and external surfaces should be cleaned daily with soap and water. When the humidification is on, the humidifier chamber should be cleaned daily with soap and water, dried and then reattached. No top-up of sterile water should be done in the humidification chamber. When the equipment is not in use, clean it with 20% Shield. After use, once the baby is out, the used equipment should be cleaned thoroughly. Disassemble the incubator, especially from the underdeck area, and clean with soap and water. Reassemble the parts, sterilize the equipment by adding 20% Shield to the humidity tank and plug it off for half an hour. Keep the incubator doors closed for 2 hours. After this, clean the incubator thoroughly with 20% Shield. Incubator should be thoroughly aired after fumigation by turning it on for air for 1 hour. This is how the cleaning of incubator done in AIIMS NICU. Specific notes to be taken in mind are that spirit and other organic solvents must not be used to clean the incubator hood or panel. The sleeves of the access window must be cleaned daily, even if the baby is in. Always position the incubator in such a way that free air enters the air inlet. Place the incubator in a place where there is no direct sunlight. Check and dust the air filter every day, which is present over the back area of the incubator. Moving on. We'll see how the environmental cleaning is being done. So for the walls, we are using 20% Shield by dissolving it in 200 ml. Moving on with environmental cleaning, walls are to be cleaned daily, once in each shift. If a week has been passed by after cleaning daily, then we need to keep in mind that vacuum cleaning can be done weekly or cleaning it with soap and water. So daily cleaning involves the usage of 20% Shield solution, which is diluted in 800 ml of water by taking 200 ml of 20% Shield to constitute it to 1 liters. Nursing stations and counters to be wiped off with 20% Shield once in each shift. These are the high-touch areas. Chairs, including KMC chairs, feeding chairs, tables, trolleys to be wiped off with 20% Shield once in each shift and after every use. Door handle, bed rails, control panels, call buttons, room inner doorknob, wipe it off with 20% Shield daily. Sink to be cleaned daily with soap and water, and if it is visibly soiled we can do it daily. Biomedical waste bins to be cleaned with soap and water once in each shift. Buckets to be cleaned with soap and water after emptying during each shift. Refrigerator to be defrosted and cleaned with wet mop using soap and water weekly. Floors with AC switched off. Wet mop to be done with 20 ml of benzalkonium chloride 2% in 5 liters of water, which is to be done in each shift, if possibly twice in a 6 to 8 hour shift, and in a 12-hour shift we usually carry it out for 3 times. Deep cleaning, if any area is visibly soiled or dirty markedly, we can clean it with using it as a deep cleaning and taking the solution of 100 ml and dissolving it in 5 liters of water. Moving ahead, feeding pillows and normal pillows sent to laundry for washing followed by autoclaving daily if possible. Contaminated pillows must be discarded. Torn pillow covers must be replaced before pillow is reused. Should not be used if the cover is being damaged. If contaminated with body fluid, the blood spill management protocol of the respective hospital should be followed. ACs, surface and filters to be washed with soap and water. Surface to be cleaned on daily basis. Filters to be cleaned on weekly basis. Windows cleaned with soap and water daily. Curtains, if any, cleaning depends on the material used. If plastic panes are used, clean with soap and water. It is to be done daily. Dusted cloth, if washed with soap and water and dried after each used, to be discarded once it is torn apart and it is very dirty, visibly very dirty. Locker tops and medicine lockers, damp dusting with soap solution to be done and allow it to dry, and it has to be done daily. Now comes the usage of laminar flow. So, laminar flow is being used in our unit to prepare IV medications and for TPN preparations. So, laminar flow cleaning, how is it done? Using soap detergent only to clean the glass surfaces, and we use 20% Shield to clean stainless steel working surfaces. The air supply should be turned on at least 30 minutes prior to the use of the machine. Keep the front door open during this time so that non-sterile air can be replaced by clean sterile air. After 30 minutes, close the front panel. Put the UV light on for 30 minutes. Switch off UV light after 30 minutes. Open the front panel. Turn on the tube light and air blower. Ensure that red liquid, which is the oil, moves by 8 to 10 centimeters or is in that specific range, which ensures its adequate usage. Adjust airflow manually. Laminar flow is now ready to be used. After use, close the front panel and switch off the air blower and tube light, and we have to clean following the same procedures as discussed above. Certain points we need to keep in mind are the following. Keep the grill and crevices of laminar flow dust free. Do not keep any object on top of the laminar flow. Do not keep any dustbin near the laminar flow. Put off the wall mounted fan and keep the doors of the room closed while using the laminar flow. Moving on to spill management. This is the spill management kit that we keep it in our NICU. Spill management involves isolating the area using caution tool, no matter however small or big the spill is, protecting yourself and other persons by using appropriate personal protective equipment. Clothing, household heavy duty gloves should be used by all whoever is handling the spill management. Face mask and gown to be worn if possibility of splashing exists. Overall gowns and aprons, boots and protective shoe covers for large blood spills. Clean area of organic material by removing it with disposable towels or papers and discard in a yellow plastic waste receptacle. In a yellow plastic waste receptacle. Cover area for absorbable material, paper or cloth. Pour freshly prepared hypochlorite solution. We have to use freshly prepared 1% hypochlorite solution over the spill, and we have to pour it from periphery to center, leaving on for 15 minutes. Wipe it off and discard the material in a yellow plastic material once it has been gathered together. Clean with available float disinfection solution or soap and water and air dry. Remove the PPE and perform hand hygiene. We need to ensure that all the equipments used once it has been carried out. We need to ensure its proper disposal in the yellow plastic receptacle and properly labeling it out, documenting the spill and replacing the items used in the spill kit. Now, what is ANTT? So ANTT is an evolving concept being conducted in NICUs. So ANTT stands for Aseptic Non-Touch Technique, which as ANTT is an evolving topic, aseptic non-touch technique encompasses wide range of practices that helps in optimal safety of patient care and reduction in hospital stay. It constitutes the minute details of infection prevention, touching the non-key elements and excluding the touch of outer things or non-key elements. So what are they? The key parts are the hubs of the syringes, which are being used to inject and import the medicine which is in them to the baby or the infected patients, and also the hubs of the needles are the key parts. So these are not to be left unexposed and unprotected. Key parts such as these needs to be always taken care of and kept in an aseptic field by covering them properly. So what is aseptic non-touch technique? It is an internationally communicated set of principles aimed at increasing patient safety, reducing the infection rate and in turn promoting ASEPSIS on a large scale. So while administering any injection, what are the different key parts and key aspects that we need to take care while performing ANTT? So we need to know what are the key parts, key sites or microaseptic field. So usage of and clustering together the general aseptic field, that is the autoclaved or sterilized tray, sterile kidney tray. Then comes to the critical aseptic field, which is the gloves, and microcritical aseptic field always need to be taken care of by keeping them covered and always handling them aseptically. So the sterilized hubs or covers are the ones readily available in the plastic wraps or covers to be handled aseptically. Insides of recently opened equipment package which is sterile, such as gauze, alcohol, swipes, syringes, needles, medicines, pre-prepared under strict aseptic technique. So these are the key parts which plays a major role in conducting ANTT. So ANTT includes these key parts, that is the hubs of syringes, needles, then the opaque lining, and also this pressure monitoring line connecting ports, and this bi-extensional valve connecting ports. All these are the key parts or the key aspects in ANTT. So moving ahead. During my work years in Rainbow Hospital, Delhi, in order to curb further spread of infections, we used to maintain checklists for ventilation associated pneumonia and also for central line associated bloodstream infections. So web bundle checklist, this is the web bundle checklist that we used over the hospital there. So this was a very nice practice which was being conducted and used over there. So I like to share it with you. So web bundle includes utmost care should be taken that there are certain aspects and points and care practices which includes web bundle checklist. So what are they? Always and ensure that hand hygiene is performed no matter whatever we are doing. Head and elevation should be taken care of, and mouth care. Mouth care too early we are not doing in babies, and usually mouth care we don't do in babies. But instead of that, we can do colostrum care. So colostrum care was, what is it? Once a baby is intubated or not intubated or on no matter whatever respiratory support the baby is on, we can coat the mouth or the buccal cavity of the babies with the colostrum, that is the first milk of the mothers. So what does the evidence suggest that is that it reduces the incidence of that, and it reduces the frequency and the prolongation of the usage of all these medical equipment, that is the respiratory support. So, and also even if it is not medically suggested, we can do that as a part of nursing care in order to increase the mother's milk output by how? So once we page the buccal cavity of the babies with the colostrum, we know that the babies usually start to develop the taste and start to like the taste of mothers. So we can do that once per shift. So care should be taken that we are using a 1 ml syringe, or we can take cotton applicators dipped in colostrum and just paint it slowly over bilateral buccal cavities. Or if we are using 1 ml syringe, we can take approximately 0.1 to 0.2 ml of colostrum and paint it over bilateral buccal cavities, and we need to let it stay over there. Care should be taken that we need not to wipe it off, and we have to keep clear the lips of the babies. No crusting should be there. Sedation vacation should be followed. Draining condensate should be always kept away from patient rather than near to the patient, since it causes pneumonia. And if any visible soiling of ventilatory circuit is there, then it should be changed. Position change should be done at least 4 hourly, or even before that if there is any occurrence of collapse or any medical need. Oral suction before change, and ET tube handling should be handled aseptically. So ET suction is an aseptic procedure. So aseptically the procedure should be done. And if there is any requirement for oral suctioning, so ET suctioning always precedes oral suctioning. And ET suction is an aseptic technique. Oral suctioning is not an aseptic technique. So we should keep that in mind. Always and every time assess the need for extubation. Need for antacids are to be assessed, usually not used in NICUs, but there are certain units where we use different catheter used for oral and ET suction. Usually this point is mentioned if the ET flora is usually infected, so we need not be transferring those floras to the oral cavity. That's why the specific point is mentioned, but it is not necessary. Again, sterile saline is used for suctioning, and suction catheter after its usage should be kept in a bag. Next comes the club sheet bundle. This was a club sheet bundle checklist that we used in Rainbow Hospital while I was working over there. So What does the club sheet bundle checklist enlist? So this is the same club sheet bundle checklist that we use, and it first and foremost emphasizes on the importance of hand hygiene. So no matter whatever we are handling, we always need to perform hand hygiene. Second one is the hub cleaning with antiseptic solutions. So a very important topic I will be discussing over here. What is hub cleaning? So once we are going to inject the patient with any medication, no matter whether it be IV infusion drugs, IV infusion drugs, or bolus drugs, or TPN drugs, whatever we are injecting, no matter whether it be antibiotic drug. So before administering, we have to imply the concept of scrub the hub. What is scrub the hub? Scrub the hub involves the concept of scrubbing the hub for 15 seconds and waiting for another 15 seconds in order to dry it off, and then we can provide the prepared medication for the baby. So it involves the reduced incidence of buildup of uh, contamination and microorganism buildup. So scrub the hub concept is to be followed very innately. Usage of sterile equipments to be always maintained, and if there is any evidence of inflammation, this is the need for its continuation. We need to assess for the uh, presence of blood at insertion site. Dressing needs to be applied very correctly. If dressing is not applied correctly, there is usually the chances of kinking and the drug being not administered properly. If there is any life-saving drug being administered to the babies, we have seen that it is not going. So that challenges us, right? So that should be taken care of. And as per the hospital policy, each and every line insertion, central line specifically, no matter whether it be PIC line or UVC or UAC or leader flex, that is the femoral line, or central jugular lines, always need to be specifically dated, and all four sides should be covered adequately, and always assess for removal. Dressing should be clean and dry, and the hub is also always cleaned after its use. Dressing should be changed after 48 hours of insertion. And dressing need not to be handled each and every time, only to be changed once it is visibly soiled. And also the extension ports and the connecting ports of the central lines should be always covered in a sterile wrap or a sterile dressing. That sterile dressing cover should be changed 24 hours. Moving on to BMW management, that is biomedical waste management. So as per biomedical waste management rules 2016, there are 4 categories of waste, that is yellow, red, blue, and all infected sharp wastes. So that is white. So what does red waste include? It includes all the contaminated plastic sharps, and it involves all the plastics being used for administering, whether it be medication preparation, whether it be feeding preparation, all needs to be discarded in red bin. Second comes the yellow bin, which includes the disposal of all the sharp, all the anatomical wastes. Then comes the disposal of blood bags. Then comes the disposal of any expired medicines or drugs. All these comes under specifically yellow bags. And if there is any cytotoxic drug, so it's it needs to be discarded in specific yellow receptacle, and which is to be labeled specifically that it is a cytotoxic drug. Next, from the all last waste should be decontaminated and discarded in this blue cardboard box. It should not be leaking. It should be leak proof, and it should be adequately lined with plastic so that no leak persists. It should be adequately built that all the glass residues, especially all the vials and all the ampules, are adequately disposed of. Next comes the sharps. All the infected sharps, pins, needles, puncture needles, and the scissors or burners, needle tip, all needs to be first broken off and disposed of in this puncture-proof container. All the blades and all the contaminated sharp objects goes in this puncture-proof container. Before putting in this puncture-proof container, we need to mutilate all the sharp contents or all the sharp objects. So summarizing my topic, what are the best practices for maintaining sterilization and disinfection? We have to always label sterilized items with date and time. Follow first in and first out of using sterilized item. Maintain a clean to dirty workflow in cleaning areas. Use PPE during cleaning. Ensure periodic validation of sterilized equipment. Staff role in infection prevention is very crucial, and their involvement and maintenance in the hand hygiene performance is very crucial. And adhering strictly to hand hygiene protocols. Usage of aseptic techniques for invasive procedures. So these are my references. I'm winding up with my topic. Thank you.